Good morning, everyone. We're in a little bit of an interesting technological situation. Dina is actually my Vanna White today. She's going to be flipping through my sides. So thank you, Dina. And with that, I will move forward. We have the very wonderful opportunity to kind of work through how the topic we picked for today was how to avoid pharmacy-related NNCs, notices of non-compliance. Um, and why I picked this topic is because I'm accompanied by Megan. She's our RN and basic med trainer and validator.
Hi, good
all
morning.
all the good APD things. And we kind of put our heads together on filling in cracks for providers. This is what we do every day. She has the basic med training, she goes out there, but there's so much of that doesn't discuss like the practical day-to-day of best ways to manage, the volume of meds and orders and pitfalls to look out for. So Dina, if you'll move on to the next slide. We won't dwell on the background on us, but basically I have been so blessed to be involved with IDD group homes in Florida for 16 years. And I've been in the homes. If you're somebody that I know on this call, thank you for inviting me. Thank you for letting me see what you do every day. I love interacting with the residents. And why it's been so impactful for me to be in the homes and see what everyone does is it makes pharmacy real. It makes the programs that we build, we are motivated. And as you know, and I speak for all pharmacies, if you're a long-term care pharmacy, really, we should be always ear out for where group homes are struggling and how we can make something easier. And I will tell you, I do have a little bit of a bias. In my 16 years, I'm really tech forward. I'm sure there are many of you, and paper isn't bad. I have to say this all the time, even to, clients that we work with who love their paper. I just think that paper can be hard to organize and manage. And if you are, overseeing multiple group homes, there are just such amazing electronic platforms that help get this information organized. And I'll sprinkle some of that throughout the presentation. But without further ado, Dina, would you move me forward? So when I thought about how to present this, I'm hearing the voices of some of the people I work with every day, and they're going, "This is overwhelming." And our objective is not to make it overwhelming. Absolutely, pharmacy is your partner in helping manage everything I am discussing today. But for you to do the best job, when APD is actually there and we're not, these are the areas that we've boiled down to focus that can, if you keep on top of it, can really help you avoid the avoidable notices of non-compliance. So it's basically four categories. Number one, auditing copies of prescriptions. Number two, auditing the actual MAR and or EMAR, whichever way you roll. The third area of focus is the RX label and med storage. That's a huge piece of, first you have the prescription copy, then you have the documentation piece, and then thirdly, we want to make sure that the physical medication, the label, and putting it into storage all adds up. And then the last area where I do see people struggling a little bit more nowadays is that I know I just said that I'm a huge proponent of weaving in digital platforms into your pharmacy and med management program. That doesn't mean that it's set and forget. I say that all the time when people move into EMAR and they're so excited and they're like, "This is life changing." I'm like, yes, but with power comes great responsibility. You still have to know your platforms and you have to make sure that staff can navigate and log in. So it still does take daily management. Dina, next slide, please. So the first area of focus to avoid the notices of non-compliance is prescription auditing. And I am boiling down auditing copies of prescriptions, Megan and I, into two big categories. Number one, and I think this is a general theme of pharmacy and a med program, is being organized. For this to run smoothly, you really need to keep copies of prescriptions organized, whether you're doing them paper and you have the good old-fashioned book in the group home, or if you're doing it digitally, there still needs to be a method to the madness. How do you, and I ask questions throughout all my presentations, but they're more to poke at you as leaders, to answer these questions for yourself. How do you keep prescription copies organized? And do the people you work with understand the system? That's a big piece of it. So one is organization, paper, digital. Now, I don't know how many people know this, but if you look at 65G7, it does allow you two options to have on hand when a monitor comes. It says copies of prescriptions or pharmacy profile. I know I can't hear or see any of you, which Dina, if you want to unmute them, anybody raises their hand, I'm open to that entirely throughout the presentation because I welcome interactive. But for those of you who don't know what a pharmacy profile is, it's basically a report that's generated by your pharmacy provider that should list all the active medications on chart. And that showing that in lieu of copies of prescriptions is acceptable per 65G. So it's whatever stroke you want to use in your home. But let's say you're not doing the copies of prescription and you're using a web-based pharmacy profile. How frequently do you access this? How often are you looking at that data? So number one, getting organized. After you're organized and you maybe have all your prescriptions in a digital website or in the book, they're organized. What's the next step? And now you got to look at them. You got to look at your orders, right? And when you're looking at prescriptions, what should you be checking for? I hear myself asking that question and thinking we could talk all day about prescriptions and the things we're seeing in pharmacy and IDD and psych orders. But my topic is notice of non-compliance. So I am highlighting the four things that I'm encouraging you to look a little closer at that APD is finding, right? By the way, I got these areas of weakness. It's been a collaborative effort. I reached out to regional medical case managers for some feedback, working with some of group homes that we know, hearing, what monitors are saying. So this should be all very relevant. The first thing you want to make sure when you're giving a prescription copy or review is you want to ensure all of the required prescription components and parameters are present as applicable. And I have details on that on the next slide. So that's number one. Number two, here's, if you have a prescription order that has very specific instructions, you should flag that order. You want to make sure that that's something you follow up with in your reconciliation efforts, which I'll explain later in the presentation. Third topic, and how many of you can relate to this, monitor for expiring prescriptions with a focus on PRN and non-cycled orders. I know that it's like, well, isn't that pharmacy's job? Yes, pharmacy should be super on top of your cycled med prescriptions. I always tell clients that pharmacy really can't cycle your medications if they're working with an expired prescription order, right? So that, let's say 70 to 80% of your medications are cycled. So really the only orders that you should be focused on, making sure they don't expire, because it's a partnership with pharmacy. We don't always know when you're running out because it's the nature of PRN and non-cycled orders. So those are the ones that do slip by us. So monitoring for expired prescriptions. And then the fourth area that is really tough, I'll be honest, I understand your struggle, is making sure you have a discontinue order for all the orders that actually require a DC. And I know that that's tough because how many times does a prescriber tell you, oh, yeah, we're going to send pharmacy a DC order for that, and it doesn't come? So then what? There are still ways that we can, together, your pharmacy provider and you can clean that chart. There are still ways. So Dina, if you can move to the next slide. So I think on the previous slide, it said the two things when it comes to auditing prescriptions, you want to be organized and then you want timeliness. Why did I mean timeliness? It's really, if you wait to audit mass quantities of prescriptions, if you don't incorporate this in almost an everyday job, it's overwhelming. And I see how this happens. I see how it happens in the group homes. You lose a key player, somebody who was doing this all the time. And then we have to kind of cover for them and, look back at all these prescriptions. And I really feel for you when that happens. And I know it happens because we get engaged. When people reach out and they say SOS, like I need help, we do. But ideally, something situational doesn't happen like that. The best practice is reviewing new prescription copies as you receive them. As it, you get either a paper copy or it gets put into a digital database. And let's say, you miss a day or two of doing this, build in a weekly QA practice. Kind of look back at the week and see what orders were new and look at the copies of prescriptions and screen them to make sure that it has all of this information. So I don't really see that we run into issues with the client name. Usually every order has a resident name on it. Where I am seeing prescribers are skipping steps is they're not putting in diagnosis. And what we do, I can only speak from our scope, is to the best of our ability, we try to help our clients with completeness of orders by, if it's missing a diagnosis, we will enter one that is, agreeable with the med prescribed, but we really prefer when the doctor writes the order from their prescribing perspective, because there's a bunch of different reasons why you could be giving a certain med, especially in IDD environment, right? So, really drill with them that they put a diagnosis on the prescription. The other area I kind of see sometimes problematic is for those of you who do have someone in the home who maybe are by mouth and sometimes receive things via G-tube. Maybe this is more in the ICFs, but sometimes those routes get confusing. And then lastly, of course, the infamous PRNs and the need for chock full of parameters. So, I get people, how do we get ahead of the PRN parameters? Well, I'm really glad you asked, because Dina, if you move to the next slide, we try to get creative. So let's start here. When PRNs roll our way, if I get a PRN order and it says doesn't have any parameters on it, of course, our course of action is to try to reach the prescriber's office, right? And go, hi, you wrote affected area. What is the affected area? How often does it need to be given? What's it for? And we go through all of these things on this PRN medication instruction sheet, right? But you tell me how, in this healthcare climate where more and more providers are in this clinic mode, sometimes it takes 48 to 72 hours to get this clarification that we need. So really, I've been encouraging our group home partners, like, get ahead of the clarification and bring resources like this with you to appointments. Like, insist. I have clients who are successful with this. This sheet on the left, this PRN med instruction sheet, is just a courtesy form that we offer, that we say, take a stack, bring it with you to the office. We see prescribers filling this out. It's kind of like their step-by-step worksheet to make sure that the completeness of the PRN order is there for APD happiness, per 65G. The other way that I see people doing this is if you look on the right hand of the screen, we see a lot of providers use a standing orders sheet that have the most frequently prescribed PRNs with check boxes, and we help them write those orders to absolute completion. Hello? Oh, hi, Terrence. We help them write this to completion, right? So look at the acetaminophen. It says take 2 tablets by mouth or G-tube every 4 hours as needed for pain or headache or temperature over 100. And here's the key part a lot of people miss: not to exceed 6 doses in 24 hours. Call prescriber if no relief after 48 hours. In the ideal APD world, this is what you'd have, right? Like the completeness of these orders. And it's what we try at every day. I sometimes I see chats. I'll review them all at the end, but I did just see one come in that says, how do I get a copy of the order, this sheet? Anybody who wants resources after this, whether we work with you or not, I am happy to help. My email is on the last slide. Just reach out to me and I'd be happy to share whatever you would like. Dina, will you move to the next slide? So the other thing I want to emphasize when you're in auditing prescription mode is clarifications matter. So I remember there was on my things to look out for on prescription copies is it said orders with details, right? And this actually was something that crossed my desk more recently. Here's a beautiful alendronate order, right? This is, everyone knows it's given once a week. On this order, I guess originally the group home was giving it on Saturdays, right? And for whatever reason, it had to change because the group home said Saturdays became really difficult and they want to start giving it on Thursdays. So pharmacy says, okay, there's nothing clinically wrong with giving it Thursday over Saturday. It just needs to be given consistently once a week, same day. But you see this little box down here. Does anyone see where it says okay per prescriber to give on Thursdays per Mary? Like those clarification notes are extremely important for things like this because APD is going to look for it. They're going to see a discrepancy that the order said Saturday, and maybe on the MAR, you are charting on Thursdays, and they're going to want to know that that was an acceptable change, right? Also on this note is, oh, and by the way, pharmacy providers across the board have the ability to put clarification notes on orders. So again, I'm really trying to come from an educational standpoint today. I'm trying to give you advice on things you can ask any pharmacy provider, even if you're not working with us, right? The other thing, if you take a note on this order, is it says do not crush. I just had a healthy interaction with a region in Florida that one of the monitors was saying that was inquiring whether all those pharmacy recommendations need to be on the original order, and they don't. If everyone's following me, there is a difference between pharmacy recommendations and prescription directions, okay? And I did get this clarified with APD because the monitor was saying not all of the prescriptions come in like this, where it's beautiful and it says includes the pharmacy recommendation. But a lot of times we get an order and pharmacy's obligation for safety is to write additional recommendations that you will find on the RX label, you will find on the MAR, but you will not find on the prescriber's original order. Take with food, take on an empty stomach, separate eye drops by at least 5 minutes if you're giving drops. So Interesting fact for today, if you learn nothing else, you do not need to have pharmacy recommendations on copies of the prescriber's original order. Dina? I'm not going to dwell too much on this, but for anybody who hasn't seen what a pharmacy profile report looks like, ta-da! This is what it looks like, and it's usually generated through some sort of portal. And the big takeaway about this is this should be a list of all of your active, all of the active orders that pharmacy has on chart for your resident. But I do want you to pay attention to one critical field here. Remember, we were talking about expiring prescriptions. I'm asking you, and you can belt it out loud for me to not hear, but everyone in your room with you can hear. What are the rules of date written? Does anybody know when a prescription expires? This is critical because this is the field on a prescription copy that dictates when your order expires. And I love this pharmacy profile report that very easily shows you. If you look in this column here, by the way, this was from a test patient that we have. You see date written October 2nd, 2024. Does everybody see that in the right-hand corner? Date written October 2024. So when did that order expire? If it is not a controlled medication, that order expires in 1 year from the date written. So that order is expired. That expired October of last year, 2025. If you work your way down this list, you see that many of the other orders are in acceptable range, starting with the clotrimazole and the glipizide. Those are all current. But if you have access to a report like this, it can be a game changer to build into your weekly QA, looking for PRN meds and pesky out-of-cycle meds. This has been really effective and helpful for orders to shout out at you that need to get either renewed or discontinued, right? When a medication prescription expires, it pretty much goes one of two ways. You get a new one or you discontinue it. So again, offline, if anybody wants more information on accessing a pharmacy profile report, reach out to me. Dina, can you move forward? So with that, focus area number one, if you can really build in daily auditing of prescription copies or maybe something weekly, you can avoid expired prescriptions that sneak up, not having a discontinue order available, because if you know something got discontinued and you're looking at the copies of scripts and you don't see that DC order come up, there are ways pharmacy can help you manage it. You can call and give us if you see it on your physician notes that it was very clearly stated it was discontinued, pharmacy can just take your word for it and discontinue it. There are ways you can document a discontinued through pharmacy portals that actually logs a DC order through that. Insufficient parameters you're going to avoid if you use some of the resources and bring it with you, to the appointments. And specific details going on reconciled. If you earmark a couple of those orders that are problematic and you make sure that the specific details on the prescriptions match the MAR and match the RX label, you're cooking with gas. Okay, next slide. The second area to keep on top of is MAR auditing, right? So first, and there is a method to today's presentation madness. First, we talk about prescription copies because that's like the building blocks of keeping on top of things, right? Secondly, you want to audit your MAR, actually what's getting charted on, where the staff is signing. The pitfalls on the MAR. What do we look for? Number one, all the time, we look for holes. Holes are an invitation to an auditor saying, investigate me. Let's not give them an invitation. Before, and this could be, again, another daily or weekly practice, look for holes. Was it given or was it not given? And let's rectify. If an order requires extra documentation, was it documented? And an example of this that comes to mind is, an order that very clearly says, take blood pressure prior to administering. So if APD sees that you signed on that order, the next question is going to be, where is that vital sign, right? Where is that blood pressure reading? You should definitely make sure that that's available on the back of the MAR or in your EMAR somewhere. The other thing to really kind of hyper focus on is looking at orders with directions that are for X number of days, right? Antibiotic therapy for 7 days, or maybe a shortened therapy, giving a cream only for 30 days, in hopes that that clears up the rash, right? If you see orders like this, ask yourself, is that therapy discontinued? And if so, when? Make sure that that's reflected on the MAR, because we're getting a lot of feedback that there's signatures beyond the DC date or end date. And you and I both know I'm preaching to the choir, but there should not be signatures past the date of discontinue or the end of therapy. PRN meds. So if you chart on a PRN med, which is fine, that's the whole reason they exist. Did you indicate the reason for giving that PRN med? So this actually came from a Miami area APD. They said that they're seeing fine that the med was charted on, and they're just not seeing, like, if it was Tylenol, that the staff is indicating if it was given for pain or fever. So they would like to see that reason. And then after you indicate that reason, there should be some sort of follow-up to the administration, a directly from 65G 70.005. It's called response to the medication. So if you gave the Tylenol for fever and fever was 102, hopefully the documented response to the medication is fever declined 99 temp, at the time that you document the follow-up. But I think the most important piece of MAR auditing is reconciling the MAR with copies of the prescription or the pharmacy profile report to make sure that it aligns. And I'm trying to be very careful of using the word match, like matchy, because they don't have to match exactly word for word, but the meat and potatoes of the prescription order and what's available on the MAR or the EMAR, that should absolutely align. Dina, next slide, please. So if you are carefully looking at MARs or the EMAR on a daily or weekly practice, you should be avoiding missing documentation, an order on the MAR that is very different from the prescription order or has a key detail that's different, like that Thursday and Saturday example. Missing PRN documentation, whether it was the reason or the outcome. Medication is discontinued, but staff is still signing given on the MAR. Let's try to prevent that from happening. And the last one, and I didn't talk about it at all because I feel like I could give a presentation. Actually, Megan can. She's pretty good at this. Like how to manage that golden control count sheet. Because that still is problematic. They have found that there's either incorrect control counts or missing sheets. So maybe next year, whenever the ARC invites us again, we review the APD control count sheet, the ART. Dina, next slide, please. So the third area of focus, because this is all building on each other, copies of prescriptions, making sure that copy of the order is presenting appropriately in the MAR. And the third, the most important piece, and this is all, why are all these rules exist? Why do they exist? Because we want to keep the residents safe. We want to give them the orders that the doctors intended for them. And the third big piece of this is the RX label, making sure that when you actually receive that medication in hand, that RX label on the card, on the baggie, on the inhaler box, on the cream, wherever it is consistent with the order on the MAR and the copy of the prescription. This is the cherry on top, right? And in my humble opinion, the best way to audit the RX label is upon receipt of the medication delivery, and before it's placed into storage. Oh man, if we can hone some internal group home practices that ensure that when the med is received, the copy of the prescription is consulted and the MAR reflects that, like what it says on the RX label, before it's stored, we could avoid a lot of heartache. And by the way, this is where organization really comes into play. If you have organized copies of scripts and your paper copies of MAR or your EMAR, which is available 24/7 on any computer, if you can access that quick and reference copies of your prescriptions quickly, it makes this final piece a lot easier than playing the find the paper game. Lastly, we love what we call cart to chart audits. This is cart is slang, for a med cart or your med storage. You don't have to have a med cart to have excellent med storage. It does help. But what you do is if you go to the med cart and you pull something out of the med cart, you want to make sure that is you're kind of auditing. Look at the MAR. Make sure that med you pulled is an active order. Make sure there's an active prescription for it. And if you do this process and you do a cart to chart audit or you cherry pick certain things to look at, it's going to help identify discontinued meds. And discontinued meds need to be removed from the storage area, because what happens when you leave discontinued meds in the storage? They're given. A lot of the times they're given. So we want to take every little step that we can to prevent these simple mistakes, right? The other thing is, please, and I've learned this over the years, it was a learning curve for me, you have to make sure you have a med available for all active prescription orders per resident. So this came up with PRNs, I was asked. If you're going to have standing orders, like I showed you a couple slides ago, where it's like most residents in your group home have a signed order for a year for acetaminophen, loperamide, tummy fever, those kind of meds, I highly recommend you make sure that you have that PRN available for the resident to take when they need it. Because I remember a group home, this was maybe 4 or 5 years ago, had an issue that when APD was like, oh, okay, you have all these standing orders for PRNs, like where are they in the home? They didn't have them. So you could have stock bottles available for that. You can have them, in bingo cards or however your system is. There's a lot of ways to accomplish that. Can you go to the next slide, Dina? I don't want to, again, another topic that is loaded, and I feel like we can spend another hour talking about this, and I can provide this. I have an actual abbreviated checklist for those of you who are feeling super motivated after this and you want to hit that med storage and make sure it gets a nice cleansing. Highly recommend. In fact, text me a picture of your nice med storage and I'll send you some swag. Med storage auditing abbreviated checklist. So are the meds organized by resident with appropriate dividers? Or do you have a system of organization? And the reason I ask that is, how many times have you received the med and then the staff's like, I can't find it? Like it was there, it got received, and they can't find it, right? That's why this is, like, to me, the last piece of avoiding these notices of non-compliance. Like, that creates med unavailable. But APD did note that they are having an issue finding that med storage or med cart is, you want to make sure it's locked when it's not used. They're finding that they can, like, walk up to it and open up drawers, and that's problematic. But this is the short list of things to hyper focus on when you're looking at your storage that can really help prevent further issues. Controlled med storage, double lock, empty containers or de-seed meds that shouldn't be there. Are your treatment meds organized? Do you have meds that require refrigeration in a refrigerator? That's helpful. Are your liquid bottles clean? Because they do look at cleanliness in the group home, especially with meds. If you can present a really beautiful, clean home and med storage, I feel like it gives them it's like you're already ahead of the game. You're like they're mentally cheering for you. Um, do you have an overstock of any med? Overstock is not good. You want just enough that you need to finish out like the cycle and then reorder. Overstock needs to be addressed. It should be removed and destroyed. Um, do all prescription strength resident specific meds have an RX label? Why did I say it like that? I said it very specifically like that because for many years, and APD, and when they updated 65G in 2019, they directly addressed this. They do not require that you have an RX label on over-the-counter products. Okay. So if that's something you want to talk about offline, we can, but you are required to have an RX label on everything prescription strength and resident specific. But that does not apply to your stock bottles. That can be in the home. But if you do have those stock bottles, keep an eye that they're not expiring. They usually have very generous expiration dates, but that can get you. Dina, could you move forward, please?
We
And then
did have
lastly,
one question real quick,
short,
Kristen.
short.
Is there a template or program to do an EMR?
I guess the way to answer that is there's about 100 EMRs on the market, but I would be happy to, whoever is asking to, if you're looking to learn about EMR products, I can, give advice or recommendations, or if you're asking if there could be a template created in your EMR program, which way do you want me to go with this? Because maybe you can create templates in your EMR. It just depends on the EMR product that you are using in your home.
Lily, did you want to expand on that? Your question? You can unmute and ask.
Hey, so we currently aren't doing an EMR at all. Like it's not electronic, it's all paper based. So I just didn't even know where to start.
Let's meet if you want. And hi Lily, nice to meet you. I'd be happy to give you some advice offline. I have some great recommendations of successful programs that are very group home friendly, and I maintain personal opinion, but I think they're game changing. I think it helps you get so organized and view your data, especially if you oversee multiple group homes. Even two, it means it's one less drive to another site to look at that paper that's there. You can view that all available online.
Okay, thank you so much.
You're welcome. Anyways, my fourth area of focus, and I won't overly dwell because I do want to leave for questions, is if you are using, and I really hope at this point, even if you have a lot of paper and you still do things with paper copies, there still should be some form of digital managing, some sort of platform that helps fortify your med information, okay? So if you have any of that integrated in your group home practices, make sure all of your staff knows how to log into the applicable programs, whether it's a portal, a communication tool you have with pharmacy, the EMR, a prescription management database. And I would also make sure that they can navigate these important platforms. I have seen where there's these beautiful platforms in place where it is eliminating the need to have side effects papers in the group homes. Those are now side effects and drug monographs are almost entirely, if you have any of these platforms, can be just accessed digitally. That's one less tree we're killing. But if the person in the group home can't show APD where to find it, that's a problem, right? If APD sees, can you pull up a MAR for me? And they don't know how to do that or print them, we want to make sure that these fabulous tools we have, everybody's trained and retrained. Because I can even say for pharmacy, it's something we focus on for our staff here. Your platforms are everything. So people should be well versed in them. Confidently manage an EMR if you have one. And if you have an EMR, highly recommend some key players know how to add a med order on the fly. This is for when, even if you had a med transferred to local pharmacy and delivered to your home, like if the timing isn't right where pharmacy is entering it in time for you to chart on that order, almost every one of these platforms allows you to add a med order on the fly so that you can instantly chart on it and not miss a administration record. Could you move forward, Dina? So if you have a really good grip on the storage practices and RX label and electronic platforms, you can avoid meds found in storage that don't have active orders, meds not being locked up. Oh, please don't pre-pour meds at the med cart. I know that I didn't specifically discuss that, but that is a no-no. Any advanced preparation for multiple residents, that's how meds get confused and the wrong cup handed to the wrong person. And you can avoid an inability to navigate key functions like ability to access critical documentation, like, finding a note in your platform, demonstrate where to access side effects. And marking a resident out of facility. This applies to MAR and EMAR users. Please, please, please. If you have paperwork somewhere that shows, let's say, hospitalization, that someone was in the hospital for 7 days and then they came back on that 7th day, right? Make sure you're not still signing resident out of facility beyond the point of when your resident actually returned. Because that's interestingly something that has been popping up per APD feedback, like reconciling when somebody's back in your home and that the MAR lines up with that, with the signatures. Could you, and conversely, next slide, please, Dina. So with that, because I know I'm running out of time, consistency across all fronts is the goal. I know I gave a lot of information today, and I do not mean to overwhelm. In fact, I'm just trying to break it down. I don't believe there should be any one person who's responsible for these jobs. In fact, that's the dangerous thing. I'm seeing that a lot of these group homes have these super hitters where there was one person who knew how to do this job well, and then they leave. You really need multiple people auditing copies of prescriptions, checking that it lines up with the MAR and making sure that the med and the RX label is consistent with it. And then bazinga, that it's put in the med storage appropriately. That way everybody can find it. If we do these things, we can have really seamless visits when monitors come in. Next slide, please. I just challenge you to ask yourself, now that these areas have been identified, how can you implement them? And ask yourself, I hope to provoke you today in a good way, thought provoke for improvement. Like, who's responsible for this in your home? Can that one person do it all? Do they need a helper? Is there a need for cross training? Are there resources you saw today that could help you either at a doctor's appointment or MedCart storage checklist, or any resource can help do that job quicker, better, more efficient? Do you have any training needs for the manager level or the staff level? What does that look like? Or your platforms, where do you need the extra help? And every organization is going to answer this differently. Next slide. So with that, I'm going to end on try to incorporate the prescription copy audits, MAR audits, storage, and RX label into a daily med routine, if possible, to lower your chances of receiving a pharmacy-related NNC. Communicate with your pharmacy provider. They don't know where you need the help if you're not vocalizing it. If person A, you feel like it's rolling off their shoulder, escalate it. Say, I'd like to speak with your manager, because there's going to be someone at your pharmacy who cares and is going to get you the help that you need. And consider requesting refresher trainings on anything, platforms. If there's an area you're struggling, see if there's a resource that can be created. Maybe I didn't show it to you today, but maybe it's something where it's special for you and the partnership, you can have a resource created. Or does your organization need to look a little closer on refining med management policies and procedures? That's something pharmacy can help with too. It all depends on what you need. But with that, Last slide, please, Dina. The end. Thank you for tuning in today. As promised, I have my number there, my direct email, and I would love to hear from you. If there's anything I can set up, facilitate, help, educate, recommend, we are here for you. And by the way, I'm really sorry. My left eye has a very fat, ugly sty. I was considering to wear a patch, but I didn't want to look like a pirate today. So here I am. And thank you for your time and attention. You've been an awesome, quiet audience.
Great. Thanks so much, Kristen.
Thank you,
We can go ahead
Kristen.
and open it up for any questions that anyone has. There is one in the chat. Is it okay to have an EMAR and signature and initial it online?
I guess question one, is it okay to have an EMAR? Yes, 100%. And an EMAR inherently means that you'll be only digitally signing. Like that is the only way staff are gonna, I mean, unless the computer is broken, we usually help group homes with backup resources. Like if internet is down, then what, right? But if I'm understanding your question today, the answer is yes, you can have an EMAR, and yes, you can digitally sign. And no, if you are committed to an EMAR program, you can do away with a paper MAR. You do not need to have both in the home. You just really need to know your EMAR platform.
Great. So, and we will send a copy of all of the presentation to all attendees, along with Kristen's information as well. Okay, one more question. As a waiver support coordinator, I don't always get information when medications are discontinued. Can I get the MAR directly from the pharmacy?
Hey, Mercedes. Now I'm seeing the chat pop up, so that's helpful. I think that's really dependent on the pharmacy. I know a lot of our group homes, like they'll request, okay, so this portal I'm talking about, right, is an electronic portal, and actually you can print a MAR from it. So I know a lot of our clients will, if a waiver support coordinator wants that extra copy, you know, a MAR for their own, you know, individual resident, a lot of times they get that through the group home. The group home will ask pharmacy. Could you ask pharmacy? Sure. It just depends on the pharmacy provider. I usually recommend to go through the group home because you have those resources to get you that copy that you need. They know what to ask. They know how to ask pharmacy better for what they need.
Great. Okay. Do we have any other questions or comments? Okay. Well, again, a lot of information. Thanks so much, Kristen.
Thank you, Kristen.